Mount Sinai. One thing Evan didn't mention is that although I am all those things, I am a former ED guy at Mount Sinai. So it's just been a little over a year since I left on a deployment, and the federal government gave me another opportunity. So I kind of jumped on it. But I miss Sinai and I miss you, Evan. So with that said, let's talk about some ethics as it affects the ICU. And I guess for additional background, I did anesthesia with the intent of being a critical care anesthesiologist, started in critical care before I went to emergency medicine. And so my clinical practice has generally over the last 30 years involved some kind of critical care / resuscitative capacity. So as an ethicist, it is of particular interest to me. For our objectives today, I'd like to define ethics, morality, what exactly is bioethics, talk about some of the principles that affect us in the ICU as far as bioethics is concerned, give some case studies, and just give a sort of bird's eye view on what the healthcare ethics committees and consult service can do for you. So, what is ethics? These are all my definitions again. Well, I was a philosophy major many moons ago. Let me not date myself. But I would say for almost the 40 years that I've been in that space, ethics to me is more of a discipline that studies a formal body of principles that have something to do with rights and wrongs, right? And again, it is more of a formal study, whereas morality is something that we each have. It's our own personal guide to what is right and wrong for us. So what does that mean? That means that sometimes morality is in contrast to an ethic or a body of ethics. An example I like to give for those of you who watch NCIS, I used to be on CBS. I'm not even sure if it's still on, but definitely Netflix. There's a character there, Dr. Dickie Millard. And he once said, the ethical person knows it's wrong to cheat on his partner. The moral person wouldn't cheat on his partner. And so again, there's the ethics of talking about it and the morality of actually walking and living it. I'm sure all of you have heard to some degree of these ethical principles. They're commonly referred to as 4 classical principles that start with autonomy or right to self-determination. It involves beneficence, which is another way that the Hippocratic Oath taught us to do good, versus non-maleficence. Again, another throwback to the Hippocratic Oath that says avoid harm. And then justice. And justice is a little complicated, and I'll go into it in a little bit. But justice basically says we should be fair, we should be equitable, and we should make sure that things are sort of and appropriately displayed, meaning that everyone has the right to know the whys behind decision making and that it doesn't favor any one group over the others. Beecham and Childress are the folk who sort of brought this to the bioethical community in the late 60s to early 70s. And many folk, touching on, again, on justice, many folks sort of confuse equity and equality. And here's a little, I think a picture is worth 1,000 words. As you can see on the left, equal treatment, equal opportunity, whereas it's not exactly fair for everyone. It might be fair for some, but it's not fair for everyone. On the right is equity. And this is, again, providing everyone with opportunity for the same access to the same end goal. Okay. So when, and this is a bird's eye view, and although you are all critical care folk, I would argue that in your day-to-day, you are confronted with ethical issues. And although you don't have to make a very in-depth ethical decision-making that a healthcare ethics committee may do. But if you can just understand sort of the background of how to approach things, it will allow you to come to a decision, possibly without even utilizing anyone else. And so, like anything we do, right? If we're going to start a process of inquiry, we should get some background. We should get the facts. And in this particular case of an ethical inquiry, we should find out what the issues are. What are the ethical issues? If you have that knowledge, maybe attach a principle to them. And often case, you'll find that there's a conflict, right? The patient wants X, you want Y, the daughter wants L. There are conflicting issues there. Next step is to find out if there are rules or guides that can help us. Oftentimes, so at Mount Sinai, there's a huge body of ethicists and ethical codes and rules that have been established there in our hospital policies that may provide the answer for that question or issue that is in front of you. There may be state laws or local ordinances, et cetera, et cetera. Now, with all of that, you then do what's called moral reasoning, and that basically weighs. Some things have more weight than others. So, for example, an autonomy issue, a patient who has capacity, who says, I want to do X, and family or you, physician, wants to do Y. There may be more weight added to someone who has capacity, and they're making an autonomous decision. And so we weigh those out. Then we have what is left, which is a most pertinent, most relevant principle. And then we have what our ethical decision should be. Now, there are tons, hundreds of examples of ethical issues. These are just a sample that I think are pretty common in my ICU practice. From autonomy, surrogate decision-making, issues of confidentiality. Are we allowed to tell person X when it involves the care of person Y? Of course, I'm sure if you've been doing this for more than an hour, resource allocation has probably touched your practice. End-of-life care, professionals' rights and duties, and conflicts of interest. So let's go into our first case. And I'm going to ask you all to suspend what we as physicians tend to do all the time. I'm purposely in this first case asking you to do something a little different, namely, forget the medical history. Forget all those nuanced details of what might have brought them into your ICU, and just focus on the conflict for right now. And I found this to be a good test for us physicians to learn to look at the ethics and not look at it just as intensivists. And so, in this case, we have a 78-year-old male, status post some issue, intubated, he's day 22 in the ICU, no advanced directives, no next of kin, or rather, he has a next of kin, that's a son, but no one has been able to reach him. He needs to be started on hemodialysis due to his worsening electrolytes. He needs a tracheostomy since he's failed his spontaneous breathing trials. Most importantly, we need to figure out goals of care. So what do we do? What are our next steps? So, as I kind of suggested in the previous slide, what are the issues here? Try to just figure out what's at play. So I think this is a sample. I'm sure you may come up with different, but this is something I came up with. End-of-life care, leading, autonomy, surrogate decision-making, concept of medical futility, beneficence, and non-maleficence. Again, just a sampling of potential things that could be here. And so now what do we do with this? Let's break it down. So we have no advanced directives. We have no known goals of care. He's not DNR, DNI currently. We have no memorialization of this person's wishes when he had capacity. Although there's a son listed, he's not available. We don't have a decision maker, no surrogate, no power of attorney, no healthcare proxy. We have nothing. And just as a quick review, this varies by state, but generally speaking, if we're looking for somebody to make decisions and we have a choice of folk, the hierarchy of who we would choose tends to start with the person's spouse or domestic partner. Then, generally speaking, goes to an adult child, then a parent, then a sibling. And some states will throw in a cousin there or some other blood relative of sort before a close friend. Some states don't. So I left that out, but just so that you know. Then there's a close friend, neighbor. And then the last option, and it's really the least preferred option, is getting a court involved as a guardian. And that's for several reasons. They tend to be generally super conservative. They tend to be very limited in their scope of what they will do. And generally speaking, as an intensivist, I can say they don't usually help the issue at hand much. So, other issues that we may be faced with in this case is withdrawing versus withholding treatment. This has long been a subject of much consternation, I think, amongst a lot of docs, wondering, is it more wrong to withdraw versus to not offer in the first place? And I can tell you the ethics of this are pretty equivalent, meaning there is no more value or any wrong in withdrawing versus withholding. They're viewed as the exact same thing because it achieves the exact same end result. And so when you are having that, sometimes as we suffer moral injury and moral distress, worrying about, well, they're already intubated. Is it a wrong action to now extubate? It is not. And you can extend that to whatever it is, whether it be the vent or whether it be feeding or whatever we're doing. Futility is another concept that we come across and sort of touching on this case. When we say in general terms, something is futile, that can often, raise concerns in the ethics and philosophy community. Because when we just say futility, it is almost like a judgment. And as you can all imagine, what we may deem to be futile may not be to the patient and or his or her loved ones. And so it is always better to qualify futility from our perspective, namely medical futility, or if you like, quantitative futility or qualitative futility as far as quality of life, et cetera, But just be careful in using the term futile as a standalone. Medical futility is a real and accepted thing, and we should stick to what we know. It is in our medical opinion that this care will not provide XYZ. So, as the case continues, we've reached out to the son. He finally calls us back. He's an only child, the only next of kin. He has not been in contact with his father for a while. He doesn't know if the father has any kind of, living will or any other advanced directives. But based on his knowledge of his father and how he was, he says, and I quote, "Dad was a fighter and he would have wanted everything done to stay alive." Now, what do? I guess we have to follow this directive. We continue on. So, per the son's request, patient is started on CRRT, tracheostomy was performed. We do the medical management has sort of touched on. However, unbeknownst to the son and the team, the patient actually had remarried, and a wife is now presenting, stating that she is the healthcare power of attorney, and she was the patient was very specific in that he did not want to ever be connected to any machines or tubes. So this is obviously a major change. The team contacts the son and says, "Hey, your dad's actually married, and this is the plan." Of course, he responds back with, in a very New Yorkese, he's going to get an attorney and will sue you for every dime you have if we follow the wife's plan. Now, what do we do? How do we address this clear conflict? So, as I touched on, there is a hierarchy. Technically, the wife or the domestic partner would come first in an act whereby you have started treatment based on the only available person in that hierarchy available, i.e. the son, no wife or other family available. Well, that person still has play, as they say. They still have an opinion. We would, however, try to build a consensus, right? You have the next of kin, who is technically the wife, who needs to be brought in. And you hope that they can come to some kind of understanding, keeping in mind that they both have a shared goal, a shared interest, namely the patient's well-being. However, as I'm sure you all have experienced and know, being in New York and wherever we are in the world, not everyone gets along and not everyone really follows such niceties. So this is where sometimes risk management, legal, and or the ethics committee may need to help referee this, this decision making. I'm going to talk about another case. This is a 52-year-old. Hypercarbic respiratory arrest. He's survived 2 code blues thus far. He's remaining intubated, barely maintaining saturations on 100% FiO2, acute renal failure, electrolytes, and metabolic acidotic state. He's on multiple pressors. MAPs are barely 50. He remains a full code. Renal doesn't want to touch him because they say he's too unstable for CRRT. Our vent settings are, we're playing with them nonstop without any significant improvement. We were able to get a living relative who, you know, we had goals of care conversations with. And his sister, as it was in this case, says, hey, make him DNR. I don't want him to suffer. Let's do comfort care. She understands the physician's concerns, and we're ready to now make him DNR and comfort care. However, where I am currently in the state of Ohio, they don't have a POLST, which is the Physician Order of Life-Sustaining Treatment, or MOLST, as it's called in New York. And we just have an LST, and that's sort of an instrument of the VA system. And so one of our nurses is looking through the LST and sees something and points it out to us and says, and I quote, he writes, I want everything done to save my life, even if my family or loved ones do not agree and want the treatment stopped. In other words, he almost preempts any attempts by family to make him DNR or comfort care. So now what do you do? So again, what are the issues here? Respect and autonomy, of course. Surrogate decision maker, I think, plays a role here. Medical futility, once again. Obviously, end-of-life care and beneficence and non-maleficence seem to be a common issue in our end-of-life scenarios. So when we look further in this life-sustaining treatment that he signed when he had capacity, he mentioned that he didn't want to suffer. However, he said he's not afraid of death, but wants everything done. And again, not to have his resuscitation efforts terminated. And so within that, there seems to be a slight, for lack of a better word, there is a conflict there, right? You don't want to suffer. You're not afraid of death. You want everything done. But, you know, now all the efforts that we're going to put into doing things that I think medically speaking don't show a lot of great benefit. There may be an argument made that, are we causing you more harm, making you suffer more, putting you through a CPR process, et cetera, with pretty low prognosis and very low benefit? That could be argued as making you suffer. And so it was felt at that point that given that clear intent, we would try, but we would not prolong things and or do things that have no benefit and may cause more suffering. Now, this could have been argued the opposite way. There is no necessary right answer in this case. I think it's just the making sure you document and justify your actions accordingly, remembering the patient's wishes. So key takeaways in this case, try to understand that patient's point of view. Oftentimes, as we all know, medical literacy is low in our non-physician patients. I would even argue when I had a cardiologist in my unit. When it came to his care, he was not a subject matter expert and acknowledged that he would rather the intensivist team handle the issues and let him sort of just be a patient. When also in doubt, use a reasonable person standard, right? Sort of divorce yourself from your medical role and say, what would you want? What would you do if it was your mom, your loved one, whoever? What do average regular people who are reasonable want? And I know sometimes in New York City, that's a hard thing to find, but you can imagine a reasonable person. And then solicit early support and include folk in your decision making to get sort of a multitude of opinions. Sometimes just having the same voice of intensivists will just give you groupthink, and there'll be no one who can give that sort of differing opinion that is more like the patients or their family. Then, of course, document. All right, third case. 62-year-old woman. She's admitted to the MICU, status cardiac arrest, intubated, remains unresponsive, has no advance directives. Husband is doting at the bedside every day, wants everything done. As is typically the case, her care becomes increasingly complicated and requiring more things, right? More interventions. She needs more specialists involved. Folk have said that she is just not going to make it. Her prognosis is good. Doesn't matter what we do for her. You share these findings with the husband, but he insists that you keep on going. Refuses to withdraw any care. At this point, we sometimes wonder, is this person too, as they say, too close to the subject? Are they too emotionally affected that they can't make a decision? And as again, I'm sure you all have experienced, this is what we deal with on a day-to-day basis. There are times where we can put into question the suitability of a surrogate decision maker. So, as the question was stated, can we override this person's wishes? Or do we just continue? So, identifying some of the issues here. Some felt that beneficence and non-maleficence led here, medical futility, and then respect and autonomy. And then, as I mentioned, suitability of the surrogate and the decision-making process. So I'll let you guys just sort of think about those generally speaking, but in the meantime, life goes on. It's 6 months later. Same patient is now returned to your facility. They're sitting in your emergency department. And this time she's uroseptic. She has a MAPA 55, despite a fluid bolus and being on norepi. She's still on the ventilator from the last admission, and obviously will require an ICU bed. You have no beds, however, and your least person in your current ICU is a 40-year-old with a closed head injury, severe TBI, not yet intubated, and hemodynamically stable. So what do we do? And how do we triage this person in this case? So again, some of the ethical principles here involve justice. And as I mentioned earlier, that is a fair and equitable allocation of resources, especially when they're limited, as they are in this case. And then the principle of triage, right? To sort. Another interesting point that is often brought up, especially from many of my specialty colleagues, is, do we have a duty to care for someone that is not, quote unquote, yet our patient? And sometimes we define yet our patient as being within the walls of our ICU. I think many of us have realized that, unfortunately, especially in bigger academic and quaternary institutions, our patients sort of fall well outside the scope of our walls and our normal comfort areas. So that duty to care, is it, by whom and to everyone? These are all questions that sometimes rhetorical, but definitely things to think about. This last case the 58-year-old man who, what we call unbefriended, he's undomiciled, he has ARDS from COVID pneumonia. He has, is the case often, has no advance directives that we know. We have no next of kin. And we want to do things. We need to do things to do care. And typically these things require, generally speaking, informed consent. How do we do this without someone who is able to give us consent and no one available? So just to go into some of the background of what the ethical approaches for that unrepresented / unbefriended person, when they have no one available to guide your medical decision, you can do one of three things. And sometimes there's a hybrid fourth, but generally speaking, the three approaches are: the physician determines. That physician, generally speaking, should never be someone who's their PCP, their primary doc. Some of the pros of a physician being the decision maker in that case is that they're the subject matter experts. A con is there a potential conflict of interest? When we work at big institutions, if we are not in the, the chain, the feeding chain, so to speak, of the economics of the institution, it's less of an issue. But in smaller hospitals where there may be physician ownerships involved, there may be some degree of financial incentives to the amount and type of patients that go there. That is a real concern. So although probably not likely at a Mount Sinai, but it is a real issue if you're ever working in a smaller institution. The next approach for these unrepresented patients is using an ethics committee to make the decisions for you. A pro for that would be balanced, they're unbiased, generally speaking. A con is they don't have that subject matter expertise. And so oftentimes they're going to lean heavily on a physician for that detailed information. And then the third approach is a guardianship. So it's typically court-based. A pro, it is unbiased, is generally universally available. Unfortunately, a huge con is that it is very time consuming. And as I mentioned earlier, it's limited in scope. It's pretty conservative. They tend to be very, okay, you can do this one thing and that is it. And they will generally opt to do everything for the patient, even though you are going there to hope to limit the care that is being done for medical futility reasons. And as I mentioned, that hybrid approach, which involves more a combined ethics committee and physician role, is sort of where a lot of institutions are moving to currently, and it's something that I would recommend moving forward. All right, so I would like to now just give you sort of what I would recommend are the things that you need to do for a healthcare ethics consult request. And so as you can see here, obviously if you've tried, you've listened to this talk, you have a pretty good comfort and understanding of how to approach a conflict on your next case, but you're still hitting a wall. There's still no resolution. That's a good time to call us. If you have that difficult patient or family member who are just insisting on things that your staff is trying their hardest to appease, or they're just asking for unreasonable things, and sometimes having that outside third party, so to speak, is helpful. If it's something that's triggering you emotionally, it's way too close to home, absolutely. And again, legal or regulatory reasons, if you need help in thinking through things, if you need help in just making the clinical decision or planning care on somebody who it's not that clear. And also sometimes just to foster communication, to make sure that everyone, that it's an open thing. Maybe there's an issue involving making sure that people are aware that the care you're delivering, it's a VIP or the complete opposite of a VIP, and you want to ensure that care is shown to be delivered in an ethical manner. And that touches on fairness and justice as well. And if those issues come up and you are in a position whereby your fairness or whether your equity is put in question, you may have a third party, i.e. the healthcare team, ethics team rather, get involved in that. And so to recap, and I've kind of sped through this because unfortunately, since we're not face-to-face and we can't have a in real time conversation on these cases, I thought I'd leave time at the end for any. So just to recap, we talked about some bioethical principles, and they provide a really good foundation when you're making a decision on ethics and, as we say, your moral reasoning process. If you can remember that trying to keep autonomy and a respect for a human being's self-determination has first and foremost of the things we do on any patient that we deal with. If we remember that capacity, which involves understanding, appreciation, reasoning, and their ability to communicate it. We can also remember that diagram, that picture of equity not being the same as equality, and remembering that sometimes just having a blind approach and doing the exact same thing for everyone is actually unfair at times. And then lastly, call the Healthcare Ethics Committee whenever a conflict arises that you feel has gone above and beyond what you are able to do. And with that, if there are any questions or, I asked a lot of questions to you all. If you have any for me, I'm happy to discuss.
Thank you for the excellent talk, Al. I have a question. Actually, I have a comment and a question. As an ethicist and palliative specialist and intensivist, I try to stay away from the term limit care or discontinue care or withdraw care. I talk about it as withdrawal of artificial life support or reorient care and goals of care. The question is, is the principle of patient autonomy absolute? And what are the exceptions to that principle? Thank you.
Thank you. Evan, no fair, you have a ringer in the audience. I'm kidding. Thank you. That's a great question. And I should have known that my alma mater, Mount Sinai, with such a great ethics team that is interspersed. I'm happy to hear that you are all up and representing well in the critical care and PAL world. And so, yes, I give this lecture for folk who generally do not have an in-depth ethics knowledge. And so the language I use may not be technically some of the language that I would use myself or among ethicists. So with that being said, there is obviously no absolutes. I apologize as I am dealing with a remnant of a cold, hope. So there are no, to say that is autonomy absolute? The answer is no. What does that mean? Excuse me. I mean, essentially, for autonomy to be absolute would obviously imply a lot more than I think we'll be able to get into right now. But we have to understand that there are limitations. Capacity is the first, right? And so understanding what a patient's known wishes with capacity or previously when they had capacity is what will give them what's called agency, right? That is what we try to strive for. An ability to express your wishes with understanding and reasoning. And so when you have that, we attempt to respect it, right? We will always, we being physicians and medical practitioners, we will always be the subject matter experts who will always have more knowledge and offering to a patient. And so respecting an autonomous patient does not mean our doing whatever that patient wants, right? We may have autonomy. We can't just demand the world. And so to generally answer that question without going into a lot of some of the ethical principles that touch on that, there are obvious exceptions to it. It is a general respect for, but take it as you are still the person driving. And I hope that answered it, and apologize for my little laryngitis here.
Thank you. How often is the chaplaincy involved in discussions with pertinent others in these issues? And has that been of benefit or not?
I mean, that's always an institutional dependent thing. I know the ethics committee at Sinai, when I was there, had chaplaincy, very involved. In the VA where I am currently, they are equally involved. And most institutions I've been involved in, either working or consulting for, I've always found that the role of chaplaincy is tantamount to a well-balanced ethics committee. Our patients, generally speaking, involve and invoke the use of chaplaincy in their own day-to-day. And so in making such moral decisions for themselves and guiding our ethical decisions, I think chaplaincy is important and crucial to that.
How often are conflicts that are unresolved go to court? And when they do, what's the frequency of their resolution? In what sense, for the institution or for the family, surrogates, et cetera?
You know, again, that's, I can give you, I don't recall the Sinai numbers when I was there. I can tell you VA numbers are much less. Tell you New York, generally speaking, compared to Ohio, much less. New York and Texas, much less. So there's such a vary in community and just culture of the legal surroundings that I think really shapes that. So it's really hard for me to give an exact number. Just know that it's not an uncommon thing. And unfortunately, some areas, it's a lot more uncommon. It's a lot more common, I should say. Obviously, for example, seeking a court for an unbefriended person would be higher in areas that have a larger population of undomiciled, completely removed from society individuals, versus a small town America that is, you know, everybody knows everybody. So it really depends on where you're talking about.
What's the impact on burnout for professionals with this? Because to me, it seems to come up fairly often.
I'm sorry, you broke up. You said, what is the impact of?
Yeah, on the professionals on burnout. With COVID, we had a lot of burnout, but that was like continuous stress. But being in the intensive care field, you're frequently confronted with these very difficult decision-making and dealing with very conflicted families. So the impact on staff of burnout seems to be significant. I just wondered how often that was the case and what's to do about that. I mean, besides leaving the job, which is probably not the best thing, but nevertheless.
Yeah, I appreciate, personally, I can attest to that. I'm sure Dr. Liebner will tell you how we dealt with COVID March 2020 downstairs in the ED of Mount Sinai. It was a lot, and just life in general, even pre-COVID, and maybe now in this world post-COVID, if we ever get there. this is a major issue. I recently wrote about moral injury in the emergency department, although it could very easily have been moral injury in the ICU. Moral injury to me is just my ethical way of saying, you know, some of the issues that I think are going hand in hand with burnout, all the things that wellness advocates are talking about now, things we didn't talk about pre-COVID as much, I think, but it's definitely gotten a little more play.
Al, thank you so much for this.
There's
wonderful talk.
absolutely a tremendous amount of distress that intensivists, emergency room folk, you name it, are feeling, not only in the workloads and the demands, the high acuity of patients, the conflicts that we're constantly, you know, confronting and being part of. Working in New York City, you know, there's so much. And so those numbers, I don't propose to be a wellness expert and or a burnout expert, but it is growing. You know, those of you who may be aware of the recent act signed into law about a colleague not too far north of Sinai who took her own life in the beginning of the, you know, COVID pandemic. This is affecting all of us. And so our own mental health and well-being is so important, but it is being affected daily. And until institutions really recognize this and just more than just do the talk, really implement better ways. And I can say that that is one thing that at the VA, I was happy to be part of, why I can work from home at times, why I can be in Brooklyn, but my job is actually in Cincinnati, Ohio. You know, things like that, little things I can do to make my own personal mental health a little better. These are things that you need an institutional support behind.
Al, thank you so much for that lecture. That was awesome. I'm sorry I missed a bit of it. I had a patient crashing. And yeah, as Dr. Giwa was saying, back during COVID, we developed a system of battle buddies, which I was fortunate enough to have Dr. Giwa as my battle buddy. And so we would get to check in on each other and make sure everyone was doing well and help talk about what we were seeing, what we were doing, which I think was a really helpful way to kind of help deal with some of the stress. Is there any other questions from anyone else in the audience that they'd like to ask about ethics, or any other questions for Dr. Giwa?
Sounds like none.
Well, I think everyone is just speechless. Thank you so much, Al. It was wonderful to catch up.
Thank you. Take care, everyone. Been my pleasure.
Thank you.